Well, thank you for asking me to speak again this morning. So bladder cancer is the most common urinary malignancy, and urothelial carcinoma, which was previously called transitional cell carcinoma, is by far the most common histology that we see. Non-urothelial bladder cancers account for less than 5% of bladder cancers, and the more common of these are squamous cell, adenocarcinoma, and also metastatic cancers to the bladder. Squamous cell is much more common in parts of the world where schistosoma or schistosomiasis is more common, and that's what that ugly thing is at the bottom of the screen, and particularly in East Africa and Middle East, and thankfully not here. For this talk, I'll concentrate on urothelial carcinomas, since this is the vast majority of what we see. Bladder cancers are the 9th most common cancer in the world. There's 77,000 new cases and 16,000 deaths each year in the United States. So this is obviously still a really bad disease. From the 20-year period, 1985 to 2005, the number of bladder cancers diagnosed in the United States increased by 50%, while in a similar time period, the 5-year survival rate did increase from 75 to 81%, showing that we are getting somewhat better in our treatment of bladder cancer, but we certainly have a ways to go. The median age of diagnosis for bladder cancers is 69 in men and 71 in women. White males have the highest risk of bladder cancers, while women and African American men tend to present with more advanced disease. And one of the interesting things I think with this is not only is it related in some cases to access to care, but particularly in women, bladder cancers are often misdiagnosed and treated as urinary tract infections and things like that for several months prior to diagnosis. The risk factors for bladder cancer, environmental exposures are the top of the list, and in particular smoking. Occupational exposures are also important to consider, and in particular people who are exposed to industrial chemicals in the textile industry, leather workers, hairdressers is a big one to still remember. There's some evidence that water contamination may also be related to bladder cancer, and there was actually a good study that showed that water intake is inversely proportionate to bladder cancer risk, and in particular, an intake of more than 2.5 liters of water in a day can significantly decrease the risk of bladder cancer. So smoking is by far the biggest risk factor that we see for bladder cancer, and it's responsible for about a half of urothelial carcinomas, both in men and women. There are more than 60 known carcinogens in cigarette smoke. Current smokers are 4 times more likely than non-smokers to have bladder cancer, and that risk is basically cut in half in people who quit smoking, but it's still twice as high as it is in people who never smoked. There's less risk with pipe and cigar smoking, but it's still an increased risk for bladder cancers. People who have a longer smoking history, in particular, greater than 30 pack-year smoking history, have a much higher risk of aggressive disease. And I have not seen any good studies yet on vaporizing versus smoking, but I'll be interested to see if they have a decreased risk or not compared to cigarette smokers. Other risk factors, certainly chronic cystitis, and this is important to remember in our many patients who have chronic Foley catheters and tend towards recurrent urinary tract infections. And in particular, folks with chronic cystitis tend to have an increased risk of squamous cell carcinoma, as well as urothelial carcinomas. People with upper tract cancers have an increased risk of bladder cancer, and I think this certainly makes sense that seeding from upper tract cancers with the urine flow increases risk for bladder cancers. There was one study in particular that showed an association between HPV and an increased risk of bladder cancer, and in particular high-risk HPV. It's unclear, though, as to why this is, and certainly needs to be studied more. People who have had previous radiation to the pelvis, especially cervical cancer and prostate, of course, do have a slightly increased risk of bladder cancer. Cyclophosphamide, which is something that we don't see too much, but is an anti-tumor and immunosuppressive agent, is very well known to increase the risk of bladder cancer. There's an agent that can be given with cyclophosphamide called Mesna, which really mitigates this risk. Aristocolic acid, which is a Chinese herb, which I have never seen in real life, but always read about, is known to increase bladder cancers. And then phenacetin, which is an old analgesic, which isn't used anymore, significantly increase the risk of bladder cancers too. So that's not something that we see anymore either. So this is, of course, something that was in the news a lot. And TZDs, or thiazoledinediones, used for diabetes, and in particular actose. So there was a large study several years ago now in the United Kingdom, which did show an increased risk with both actose, or pioglitazone, as well as rosiglitazone. There was a second study that's not up here that showed only an increased risk with actose. Now, the most recent study, though, which was much larger than the previous studies, showed no increased risk for either one. And that's still a question that we get. And I think most primary care doctors have taken their patients off of actose because of the possibility of this risk, because people are so aware of it. Air pollution is thought to potentially increase the risk for bladder cancer, but these results have been very conflicting. Artificial sweeteners is something that we've all heard about over the years, and in particular, large doses of saccharin induced bladder tumors in rats. However, this was extremely high doses of saccharin and only in the perinatal period. So these studies have never been reproduced in larger mammals. Hair dyes, which I mentioned before, and in particular hairstylists and their exposure to hair dyes, is a known increased risk for bladder cancers, but there's has not been any increased risk seen in personal use. The genetics of bladder cancer, carcinogenesis in the urothelium seems to be a very complex interaction of oncogenes, tumor suppressor genes, and overexpression of normal growth factors. And I think overall we still have a lot to learn about the genetics of bladder cancer, but it does seem to be very complex, and I won't get too much into it here. The heredity of bladder cancer, most of the studies that have been done do show a small increased risk in relatives of people with bladder cancer, and it seems to be highest if the affected relatives were diagnosed at a relatively young age, or less than 60 years old. There have been multiple genes thought to play a role in two of the most studied, are P53 and retinoblastoma, or the RB gene. There's also good evidence that there are inherited differences in the metabolism of toxins, which increases the bladder cancer risk, and in particular how people metabolize cigarette smoke. And one thought is that this is responsible for the differences in ethnicity that we see in bladder cancer risk, in that some ethnicities, especially Latino people, seem to metabolize toxins different than Caucasians, and therefore have a much less risk of bladder cancer. The clinical presentation of bladder cancer is something that, of course, we all know very well here. Painless hematuria is always a worry for bladder cancer, and in general, with microscopic hematuria, there's about a 5% risk of bladder cancer, and that risk is much higher with painless gross hematuria. The risk is almost 20%, so really pretty high. Pain is usually pretty rare with bladder cancer, and it's more worrisome for advanced disease, either causing obstruction or even metastatic disease. So most of these people that we initially see do not have any pain. Irritative voiding symptoms are seen in about a third of patients, and in particular carcinoma in situ. So the things that we all know well, the frequency, urgency, nocturia, is seen in about a third of patients with bladder cancer. And I think this is always important to remember, and especially in women, where we tend to jump to urinary tract infections, and that does seem to delay diagnosis in some cases. Again, obstructive voiding symptoms are much less common, and this has more to do with the tumor location. And in particular, if the tumor is near the bladder neck, they can have obstructive voiding symptoms. Constitutional symptoms, weight loss, fatigue, these are much more worrisome and signs of advanced disease with bladder cancer. The initial workup for bladder cancer, certainly urinalysis, urine cytology, upper tract imaging, and whenever possible, it's always better with contrast. And then, of course, an office cystoscopy. And this is something that we see very commonly, bladder tumors that look like this. And I always think they look a lot like a sea coral, but something that we see a lot of. The staging of bladder cancer. One analogy that I like to use with patients a lot that I think is helpful is comparing the bladder to their cheek. I think that's an easy thing for people to understand. So about 75% of bladder cancers, when we initially see them, are superficial, are confined to the mucosal layer or into the lamina propria, or up here the CIS through T1. Now, T2 and beyond are muscle invasive. And that's about 20% of bladder cancers at initial diagnosis, and only about 5% have distant disease with the initial diagnosis. One of the most important distinctions with bladder cancer, as I'm sure you all know, is non-muscle invasive versus muscle invasive. And that really changes our treatment path. And again, the non-muscle invasive, the superficial or the carcinoma in situ up to T1 in this diagram, and then T2 and beyond are the muscle invasive. The initial treatment is really the same for all bladder cancers, and that's to get a tissue diagnosis and attempt to resect all of it if we can with a transurethral resection. And for those of you who haven't been in the operating room much, this is what a TUR looks like. Of course, it's an electrocautery loop that we use to very carefully shave tumors out. And one of the important things for us when we initially resect these is really two things. Of course, to try to get all of the tumor out that we can, but also to be sure that we get into the muscle of the bladder, because that's the most important distinction in the diagnosis of these, whether or not the tumor has gone into the muscle or not. So it's really important to be sure that there's muscularis propria in the specimen. If there's not, so when we get that initial pathology back, if there's either not muscle or if it's T1, high-grade T1 disease, so the high-grade tumors that go into the lamina propria, so that layer that's just beneath the mucosa, it's important to actually take these patients back. And this is something that has been a change just in these last few years. With high-grade T1, we know that there's almost a 30% chance that we'll understage them initially just on one resection. So this is really important that we go back and we're sure that we know exactly what we're dealing with. So non-muscle invasive bladder cancers, the prognostic factors, most importantly are the histologic stage, so the depth of invasion, and then the grade. So it's low grade versus high grade. I'm sure many of you remember it used to be grade 1, grade 2, and grade 3, and they simplified it several years ago now, so now it's just low grade and high grade bladder cancers. And of the non-muscle invasive bladder cancers, depending on which study you look at, up to 80% of these recur, and that's really important to remember, that they do have such a high recurrence rate. And almost 25% of these can progress to muscle invasive, so turn from non-muscle invasive to much more dangerous disease. Again, the stage of non-muscle invasive bladder cancers, TA, are those very superficial, just in the mucosal lining. These are often low grade, but they do frequently recur multiple times prior to invasion. And again, significant risk of progression with these, and that's why it's so important to follow these patients very closely. The T1, or those lesions that are just into the lamina propria, these are almost always high grade, and again have a significant chance of progressing beyond that layer into the muscle. Carcinoma in situ, which looks very similar to that picture there. These are the flat, often described as velvety appearing bladder cancers. These actually have a very high risk of progression and up to 45% in some studies. So these can be really dangerous. As I mentioned, one of the most important distinctions for us when we look at these is whether it's low grade or high grade. And low grade and high grade bladder cancers are really almost two completely different diseases in how they act. The high grade bladder cancers are at much higher risk for future progression. So these we need to really treat aggressively. The initial treatment, of course, we talked about transurethral resection, and something that we usually routinely do now is to add mitomycin C immediately after the resection. So this is in the hospital after we do the resection. We put mitomycin C into the bladder at the end of the procedure and leave it for about an hour. And mitomycin C was originally a chemotherapy agent primarily used for stomach cancer, but it was realized that putting this into the bladder, very little of it is absorbed systemically, but it can decrease the chance of a bladder cancer recurring by almost 20%, which is really a big deal. So this is a routine part of resections now. Many patients do complain of some temporary irritative symptoms. It's really hard to say, though, because they tend to have those symptoms after a TUR anyway, so it's hard to say how much of that is really the mitomycin C. But in general, it's usually very well tolerated. Now, the high-risk bladder cancers are, again, the carcinoma in situ, the high-grade disease, the T1 disease, so again, the ones that are just into that layer beneath the mucosa, or anyone with multiple and especially large, greater than 3 centimeter, low-grade tumors. Those are the high-risk folks. And in these patients, these are the ones that we're talking about doing intravesical BCG after they've initially healed from their resection. And again, I think this is a really important point. So anyone with high-grade disease, we should be thinking about BCG, T1, or multiple large tumors, or again, the carcinoma in situ. So BCG, I'm sure, is something that many of you know a lot about. So to review a little bit, it is a live attenuated mycobacterium, and it's been really well studied and shown to consistently decrease both the risk of recurrence and progression of bladder cancers compared with chemotherapy when used for at least 1 year. And this is an important point, that it's been shown to be much more effective when people stick with it for at least a year and often beyond. And we'll talk about the BCG schedule a little bit too. So it's important to encourage our patients to stick with it, even though many of them do have some temporary irritative symptoms with it. The mechanism by which BCG works isn't completely understood, but we do know that it triggers an immune response, which seems to correlate with anti-tumor activity. And is the most effective agent for non-muscle invasive bladder cancer. So it really has helped our treatment of bladder cancers. The BCG schedule, in general, we'll do a 6 weeks induction cycle and then 3-week maintenance cycles. And there are some different schedules out there. This is the most common one. And in people that will stick with it, if you look at this goes out to 3 years from their initial diagnosis. So this is really a long-term schedule. But again, we know that the people who stick with it for at least a year do much better. And I think this is where many of our nurses get to know some of our patients very, very well, is in these maintenance cycles where they're seeing the same patients every 3 months initially and then every 6 months. The complications of BCG, thankfully we don't see many serious complications, but the toxicities include frequency, cystitis, transient fever, and hematuria. Really important to remember when not to give BCG. So not after a traumatic catheterization, not in anyone with active cystitis, and we do routinely check dipstick UAs in the office for our patients before we give it, or persistent gross hematuria after a TUR. This is important, of course, because we worry that these patients haven't healed, and anyone who we worry has some mucosal disruption in their bladder or severe inflammation with a cystitis shouldn't be given BCG, because this is cases where we can see more dangerous infections. One question that frequently comes up is if people with prosthetic devices, so hips, mechanical valves, are at increased risk with BCG, and they're not. Thankfully, serious complications are much more rare, but they can include severe hematuria, granulomatous prostatitis, which can be very difficult to treat, epididymitis, a very scarred or contracted bladder, and sepsis. Now, sepsis, of course, is the really scary one with BCG, and now it's only about 1 in 15,000. So very rare, but it's really scary when it happens. Mild symptoms with BCG usually resolve within 48 hours. And this is an important time frame for us to remember when we're getting phone calls after BCG with people complaining, because you can have a fever within those first 48 hours, which does not necessarily mean sepsis. And if it's a high fever, they should be given a fluoroquinolone. As I'm sure many of you know, Levaquin and Cipro work much better for post-BCG cystitis than other antibiotics. Now, if the fever or severe symptoms extends beyond 48 hours, that's when we need to get even more concerned. And of course, the big concern is with sepsis. So again, that 48 hours and high fevers, especially greater than 39 or 102.5, are the folks that we're worried about BCG sepsis, and they should be the ones that we're sending to the hospital and getting infectious disease help. And if there is evidence of disseminated BCG outside of the bladder, these people end up on anti-TB therapy. And it's usually for 3 to 6 months and usually multiple anti-TB medicines. Again, though, this is very rare, thankfully. And just to go back over when to not place BCG, people with an active urinary tract infection, traumatic catheterization, or those people who have persistent gross hematuria after a TUR, then BCG should be delayed. Other intravesical agents that we use for non-muscle invasive bladder cancer are not as common because BCG does work so well. But mitomycin C, in addition to just the immediate installation after a TUR, can be used in the office. Epirubicin, gemcitabine, interferon alpha, and thiotepa. And when you look at the National Cancer Care Network guidelines that we often look at for cancer treatment guidelines, they only talk about now BCG and mitomycin C. They don't talk about these other agents anymore. It's because they're not nearly as effective. There are many experimental therapies and lots of research being done currently, and these are some of the current agents that are being investigated. With non-muscle invasive bladder cancer, one really shift that's happened over the last several years is a push towards more early cystectomies. And we know that people with very high-risk disease, even though it's not muscle invasive yet, can do much better with an early cystectomy, and it can be a life-saving procedure rather than waiting for them to progress. And in particular, the people that we tend to think more about doing an early cystectomy with are those T1 tumors. So again, those people who have gone just below that mucosal layer, who have high-risk features with their pathology. Very large tumors that can't be safely, completely resected with the initial TUR, And this is pretty unusual. We can usually resect tumors pretty completely. Patients who have recurrent or persistent T1 tumors are very worrisome for progression to muscle-invasive disease. And then finally, BCG refractory high-grade disease. So those folks that we continue to give BCG and they continue to recur with high-grade disease, those are people that we should really be thinking about doing cystectomies earlier. As we talked about, the recurrence rates are so high with non-muscle invasive bladder cancer that the surveillance cystoscopies after treatment are really important, because if they recur, we want to catch them early, of course, so that we can treat them again. And there's no clear consensus on guidelines for surveillance, but in general, most people use a schedule of every 3 to 6 months for the first 1 to 2 years, and then annually thereafter. And we know that patients with low-risk bladder tumors, so the single, small, low-grade, non-invasive tumors, we can safely stretch their surveillance cystoscopies out a little bit farther. Now on to muscle-invasive bladder cancer. And again, these are in this similar diagram to what I showed before, the T2 and beyond. So T2 tumors are into the muscle. T3 is beyond the muscle into the fat around the bladder, and then T4 is all the way through the bladder and the fat. Muscle-invasive bladder cancer is one of the scarier diseases that we see because almost half of these people will develop metastatic disease in 2 years, even with radical cystectomy. And that's really pretty staggering. And 16,000 people still die every year in the United States with this. So this is still really a very bad disease. Radical cystectomies have been around for many, many years, as you know, and it's still the gold standard treatment. And now many of these are done robotically, which does help with the morbidity, but it's still a very morbid procedure. And up to 60% morbidity, meaning a significant complication afterwards, and almost a 3% mortality rate with cystectomies. And I think much of this speaks to the people who tend to get muscle-invasive bladder cancer, because it tends to be older folks, people who have many other medical issues. And so they're often not the younger, strong, healthy people. As you know, of course, radical cystectomy includes bladder removal, the adjacent organs, so prostate, seminal vesicles in men, vagina, uterus, and ovaries in women, and then also a regional lymph node dissection. And of course, if we remove the bladder, we have to divert the urine. And the most traditional and still most common way that we do that is with an ileal conduit, as I'm sure many of you have seen. And orthotopic neobladders are used in some patients, as well as continent catheterizable reservoirs, Indiana pouches being the most common. And we'll talk a little bit more about those. One shift with radical cystectomies over these last several years has been towards giving more of these patients neoadjuvant chemotherapy because we know that this results in a much lower risk of recurrence and a significant improvement in survival. So of course this means giving them chemotherapy prior to their cystectomies. And these are typically cisplatin-based combination regimens, and they have consistently demonstrated an increased survival. Despite this, and this is an old study from 2009, but in 2009, even with good evidence of how much better these patients did with chemo prior to cystectomies, only about 20% of patients at that time who had cystectomies done got chemotherapy beforehand. And I hope that we're doing a better job now, and that's certainly something that we try to do in our group and use a multi-modality approach to these patients and really a team approach with not only urology but with medical oncology too, because these patients definitely do better. So just to briefly review a little bit the urinary diversions, since these are something that we see very commonly coming into the office. Of course, ileoconduits are the most common thing that we see, and this is taking a section of ileum, routing the ureters into it, and then bringing it up to a stoma. So these are the people, as I'm sure most of you know, who come in with urostomy bags. Orthotopic neobladders are something that are used more in younger folks. And this means, as you can see from this picture here, actually taking a pretty long section of small intestine, opening it, and folding it back over on itself to really create a new bladder. And this is then connected to the urethra. So patient selection is the most important thing in these folks because they have to relearn how to urinate because since it's small intestine, it doesn't contract like the normal bladder does. So these people have to learn to relax their pelvic floor and Valsalva to empty these. So certainly it's not for the 80-year-old patient. Usually this is usually used more in the younger patient who, for their quality of life, really wants to try to get away from a urostomy bag. A continent catheterizable reservoir, most commonly Indiana pouches. So this is using the right side of the colon with a short section of ileum still connected to it. So the colon is opened and folded over on itself to make a reservoir, and then that section of ileum is brought up to the skin and is not an actual stoma, but just a small opening that can be catheterized. Because the ileocecal valve is still in place, these people are usually continent. So this can be a nice option for some folks because it allows them to get by without wearing a bag. The most important thing with these, though, and the reason that it's not used for everybody, is they have to catheterize really regularly. If they don't, they can go into retention. And this is something that unfortunately we see, and I saw last week in the middle of the night where a lady had gotten way too full and then he can't catheterize it. And so he ended up having to usually drain it percutaneously. So these people are usually have to set an alarm in the middle of the night to get up and catheterize these. So it's much more high maintenance than an ileoconduit is. So certainly not for everybody. Radiation therapy for muscle invasive bladder cancer. Radiation has gotten better, but we know still that it's not nearly as good as a radical cystectomy as far as the survival rates. And so the people that get radiation are usually the elderly folks who can't tolerate a cystectomy. And in that case, it works pretty well, but again, not nearly as good as radical cystectomy. So this is not something that's used in younger folks who can tolerate a cystectomy. So to go over some of the important take-home points, even with increased survival rates, 16,000 people still die of bladder cancer in the United States each year. Quit smoking is one of the most important messages. There's very high recurrence rates, so we need to be really vigilant with these patients, and especially with their follow-up and their follow-up cystoscopies. BCG is really a very effective treatment, and we need to be always thinking about the folks who we should be using BCG, so those higher risk people. Early cystectomy can really save lives, and we should probably be doing more of them. Again, vigilant surveillance, and finally, we need to quit smoking. we really need to encourage our patients to quit smoking and reminding them at every visit, and really bugging them, because that is the biggest risk factor for these. What questions can I answer? Well, so again, that's a big shift compared to how we used to treat these. I mean, it used to be waiting for a muscle invasion and then a cystectomy. But we know that the survival rate is so much higher if we get it done sooner. So the selection for this is really important. I mean, this isn't the low-grade non-muscle invasive. I mean, these are the really high-risk people. So the people who have invaded into, excuse me, who invaded into the lamina propria, or that first layer, because we know that they're headed for muscle invasion, or those really large, all over the bladder recurrences that are still smoking, and we can really have an honest conversation with them and say, listen, you're headed for muscle invasive disease, and if we don't catch it right when it happens, this could kill you. So I think that's really the conversation. But you're absolutely right. I mean, it is a hard sell. It's a really hard sell. So you're well, right? I know. Oh, and they still do. They still do. I mean, they'll come in for their cystoscopies with a cigarette sticking out of their pocket. Right, right. Yeah. No, I totally agree with you. I mean, and as many of these people who end up with an ileal conduit, to tell them, we could save your life from something that really hasn't happened yet, and you're going to get a bag. I agree, that's a really hard sell. And I think some of these people, I mean, an orthotopic neobladder may be a good option. I mean, often these are the 62-year-old who we're really looking ahead. So I agree with you. I think it's an important conversation to have. But yeah. Right, and certainly that's not how we word it, but no, I agree. I agree. Yeah, great point. Please. Well, it depends on the patient, and for those of you who haven't looked at it, the National Cancer Network, or National Cancer Care Network, or nccn.org, is really helpful because it's a government-run website, and they do a really nice job of keeping up on all of the research that's out there. And so I think that's a great place to look as physicians and as nurses too. And it's either one, and I think it depends on the patient. So do you try a second-line therapy that you might not work as well, but may help? Do you go to mitomycin C or interferon alpha? You can do 2. So that's the recommendation. So you can do 2 induction courses. Yep, and that's a great question. But again, I think if they can tolerate it, all those patients, we should be at least talking about cystectomy, at least introducing it to the conversation, and maybe trying something else in the meantime. Yeah, that's a great question.
And then you're doing a 3-week for...
Yep, so 3 weeks maintenance at 3 months, 6 months, 12 months, 24 months, and 36 months. I think I missed one. 18 is in there. And that's pretty well agreed upon schedule with that. There's been some pretty good studies on that. And I think the hardest thing is getting people to stick with it. I mean, that's because we know there's great studies that show at least a year works the best, and beyond that, if they'll stick with it. But that's always the hardest thing, is getting these people to stick with it. Coming in and waving a catheter at them and all that. Yeah, good question. Yes, sir.
In our group, I'm seeing more of a trend towards younger people getting superficial bladder cancer. So I wonder if you could speak to 2 things. One, the incidence of increase related to the use of marijuana or diet sodas. Was that aspartame, which has been shown to cause bladder cancer in rats? Do you feel that there's been a shift in the population for earlier disease?
Anecdotally, it sure seems like there has been. The studies on aspartame and saccharin haven't ever been reproduced in larger mammals, but the evidence is, the worry is still there, that in high enough amounts, these chemicals may have something to do with it. There isn't any good data on marijuana and bladder cancer, but I do think, and I think eventually the studies will show it, that there is at least somewhat of a shift. And wonder too how much of that is earlier diagnosis versus truly getting it earlier. Just coincidentally though, this last Wednesday, I had a 28-year-old guy who had blood in his semen. Initially thought it was prostatitis and treated him, and then it came back, and it was quite a bit of blood. And said, listen, unlikely that you've got anything dangerous, but we need to scope you. And sure enough, scoped him, and he had a bladder tumor sitting there. So I haven't done the biopsy yet, but this is a 28-year-old guy. I couldn't believe it. So I'm going to resect it, I think, this next week. And it could be benign, but it looks just like one of those tumors sitting there. So I suspect that there probably is going to be an earlier shift.
I've seen multiple recurrences in men in their 30s, and that's concerning to me.
Yeah.
Plus the fact that women have twice the tendency with the same predisposing risk factors that males do. The question I had then, since tumors tend to recur around the bladder neck and trigone,
Yeah.
particularly around the ureteral orifice, so you do multiple resections, you go into the lamina propria,
Yeah.
muscularis, and now you have risk for ureteral stenosis.
Sure.
Now, what about ureteral reimplantation then?
I think, again, those patients, we should be thinking about doing cystectomies more. We do. Yeah. Yeah, earlier cystectomy. And especially, I mean, if it's somebody like that who we're obstructing their orifices and they're having that degree of recurrence, we should be thinking cystectomy.
Another point.
Yes, please.
The early diagnosis of superficial bladder cancer. I have seen some things on blue light laser which can show tiny lesions that are not visible with cystoscopy.
Yeah.
Are those lesions then resected to the same degree of aggression that you would with a tumor that you can see?
And I'm glad you mentioned that. And I didn't put this in this talk, but both blue light cystoscopy and something called narrowband imaging have shown some promise anyway. So blue light is introducing an agent into the bladder and then using a special light source for cystoscopy, and so it's specific equipment that can help to, the thought is, can help to better identify some of these smaller lesions and better delineate some of these bladder lesions. And it hasn't shown to increase survival yet, and it's not widespread. The usage isn't widespread, I should say, because of cost and because it hasn't shown increased survival yet. That said, I think it's shown promise, and it could be really helpful as we continue to study it. To answer your question about how these are resected, I think that's really a judgment call on the urologist's part. I mean, if it's something that looks really low grade, you may not be as aggressive as getting into the bladder or getting into the deep muscle. But it's important to always accurately stage these. So you run the risk, if you don't go that deep, of what if it's a high-grade lesion? Then you're having to have that conversation. Okay, now we've got to take you back because I didn't get muscle, and have to do a repeat resection. Yeah. So it's certainly a judgment call. But yeah, thank you for good questions. Other questions? All right. Thank you very much.